Ventricular impulse formation abnormalities. Ventricular impulse formation very similar to the atrial one, except we do have the escape bit because we do have a nodal tissue in the Purkinje fibers. We can have premature contraction when the ventricle is discharged earlier by an ectopic center located in the ventricle. This early coming bit with a bizarre morphology QRS because the impulse made by the muscle and propagated through the muscle to muscle, this QRS is wide and usually the amplitude is higher one. There is no P wave in front of the QRSs. We can have a negative P behind the QRS, meaning that the atrium is activated from the ventricle. The width of the QRS is normally wider than 0.12 seconds. The T wave, the repolarization waves, are altered, and usually the T and STT inversion can be seen, or depression can be seen. Usually the ventricular premature beats are fully compensated. It can occur in healthy people, but it's a clear sign of myocardial injury. It can have one or more centers, meaning that unifocal or multifocal. You can see very nicely the difference between a supraventricular beat and a ventricular beat. QRS is wider, bigger, and the T wave is not the same, it's inverted. Unifocal and multifocal ventricular premature beats. Unifocal, when we do have these premature beats, they always has the same kind of ventricular shape. Multifocal, when they are coming, they do have different shape. So it meaning that this early coming ventricular beat doesn't come from the same area. Here what we can see that every second beat is a premature beat, so that's a ventricular bigeminy. Here the quadrigeminy, because every fourth is a ventricular premature beat. Ventricular couplets or triplets or salvos or salves, these are couplets, triplets. And when we do have more, that causes tachycardia. In sustained ventricular tachycardia, we do have an ectopic activities of the ventricle that starts and ends. It can, a sustained one starts slower and a paroxysmal one starts rapidly and ending rapidly. They usually initiated with a premature ventricular contraction and quick and regular rhythm. The QRS is wide and bizarre. Often started with an R on T phenomenon because there is on the end stage of the repolarization we do have a very vulnerable area in the T wave, and usually we do not have any P wave, and the carotid massage doesn't help to stop the tachycardia. As you see here, this is a paroxysmal tachycardia starting and after ending. Accelerated ventricular rhythm or ventricular tachycardia, again a lower ventricular pacemaker center firing a little bit faster than in own rate, and very commonly this kind of phenomenon occurs when after revascularization or PCI intervention, and there is no need. When the heart recovers, usually this ventricular pacemaker activity disappears and the sinus activity comes back. Ventricular flutter, again the rate is going to increase, and between the contraction and relaxation there is no pause period, so no isolated climb between the QRS complexes. The rate of the ventricle is around 150 to 350, can be due to cardiac coronary artery diseases or myocardial infarction, cardiomyopathies, shock lightning, for example, or hyperkalemia, and other different medication. If we do increase the heart rate faster, now we get to the shivering when the muscle does not contract because no mechanical contraction and no cardiac output. That can be cause brain damage within 5 minutes or even death within 10 or 15 minutes. Again, very similarly with the previous one, myocardial infarction, cardiomyopathies, or shock lightning can cause this ventricular fibrillation. This is a deadly situation because there is no cardiac output, no pulse, so the circulation stops. As you see here, that's the ventricular flutter that goes to the fibrillation and finally the death. Those are the point tachycardia. Usually is going to develop in a long QT polymorphic ventricular tachycardia with a wide QRS complex, and this QRS complex, the electrical axis of the QRS complex are variable. Ventricular fibrillation can develop. Medical treatment of arrhythmias, hereditary syndromes, and therapy, for example, that they're applying beta blockers, magnesium, transitional pacemaker, which raises the frequency and sees those are the point tachycardia. As you see here, sinus rhythm, and after starting this tachycardia, when the axis is changing revolution to revolution. Ventricular parasystole. This kind of arrhythmia is caused by the presence and function of the secondary pacemaker in the heart, which works in parallel with the SC node. These parasystolic pacemakers are protected from the depolarization by the SC node by some kind of entrance block. This block can be complete or incomplete. Parasystolic pacemaker can exist in both the atrium or in the ventricle. If you do have an atrial parasystolia, this is characterized by the narrow QRS complex and usually initiated with a P wave, but the P is different from a sinus P wave. Or ventricular parasystolia, it has a wide QRS because this extra pacemaker center located in the ventricle, that in the muscle, and that can cause wide QRS complexes. As you see here, mostly these parasystolia is come regularly and come for a certain period of time. It can be bigeminy, trigeminy, quadrigeminy. These are all parasystolia can be. Only the parasystolic center can activate the ventricle of the atrium when it is not in the refractory period.